Hello, I'm Dr. Patrick Marcus, and your test results just came in. And I'm afraid I've got bad news. You might have ovarian cancer. But you know what? I'm looking at these results here, and honestly, I'm not really sure. The standard blood test and the ultrasound screening are so inaccurate. But you know what? Never mind. We're going to go ahead and take those ovaries and your uterus out anyway, just in case. 720,000 women will suffer. Billions of dollars will be spent just in case. Almost Dr. Jennifer Watson thinks she has a better way. Jennifer?
Thank you, Patrick. I'm a PhD student at the U of A, and my research is on ovarian cancer. I've spent the past few years in a dimly lit room looking at ovaries and typing away on a computer, and I thought this would be a great opportunity for me to get out of that little room and explore what comes next after leaving that dimly lit room and taking the technology to the clinic. The motivation is ovarian cancer. 2.5 million women in the US are at high risk for ovarian cancer, and there are 15,000 deaths each year due to ovarian cancer. When the cancer is caught at stage 1, the survival rate at 5 years is very high, it's 90%. However, very few cases, it's only 75% of cases are not caught until advanced stage disease. And at that stage, the prognosis is very low. For that reason, a new test is needed over these current methods, which are the CA-125 blood test and the ultrasound, which are not good at detecting early stage cancers. They also result in a lot of false positives, which mean that the test is positive, but the person doesn't actually have cancer. So they go and they have their ovaries removed and have this unnecessary surgery, unnecessary pain and burden to the medical system. The technology that I'm developing is an endoscopic imaging system that uses an advanced microscopy technique and a proprietary algorithm for automatic image classification. The benefits of this system is that it's minimally invasive as compared to an open surgery. Also, the system has submicron resolution, which is 1,000 times better than an ultrasound. And this can detect very, very small cellular changes that are happening as cancer is developing. Also, this is a non-destructive imaging technique. So the tissue that is being imaged is not being destroyed in the imaging process. And there's no ionizing radiation, so there's no risk in that term to the patient. Also, the tissue does not have to be removed. In a lot of cancers, they'll go and they'll take a biopsy. In ovarian cancer, they don't take biopsies. If they're going in there, they're going to take the whole ovary. But with this method, we can image the ovary in the body, not having to remove it, and we can have immediate detection. So we don't need to send a sample to the pathologist to review it. We can tell immediately if it's cancer or not. In a preclinical study, I found that this automated classification algorithm can classify the samples with 80% sensitivity and specificity. That means that 80% of the patients with cancer are correctly identified as having cancer, and 80% of the patients that are normal are correctly identified as normal. The cost to further develop this technology in order to bring it to the clinic are on the order of $300,000 to $500,000, and this could be offset with SBIR and STTR grants partnering with the university. Also, a clinical trial and FDA approval for a Class 3 device are needed, which is very costly, on the order of $3 to $6 million. I estimate that in order to build a device, it'll cost $100,000, and we could sell the system for about $250,000. In comparison to the existing standards, which cost $175 for a cancer antigen test and $400 to $2,700 for an ultrasound test, and if those test positive, then that's followed by a $40,000 surgery and hospital stay, as compared to this new method, which would be $2,000 to $10,000 for a minimally invasive endoscopic procedure, which would be outpatient-based. In conclusion, this new method would increase the accuracy and reduce the pain and suffering of the women who are dealing with ovarian cancer, and it would reduce the medical costs. Furthermore, this technology has the potential for use in other cancers as well.
So what's the regulatory pathway that's going to have to be achieved with the FDA to get this to market?
So we're going to have to do a clinical study and test this in a large patient population to make sure that it is actually an advantage over the existing techniques. Right now, this system is a tabletop system and it doesn't have the endoscopic part built. So that's the part that needs to be built and tested in the operating room.
So what class of medical device?
This is a class 3 medical device, which means that it's in patient contact and an invasive procedure. So it's a vigorous regulatory process.
PMA or 510K?
No. PMA, not 510K.
What's the reimbursement path?
The reimbursement.
So under the current methods of reimbursement, it would be difficult to justify a system like this because unfortunately our reimbursement system is structured such that you get reimbursed regardless of whether a surgery is necessary or not. But things are going to be changing in coming years and it's going to become an outcomes-based system. Under an outcomes-based system, this would be viable because it would significantly reduce the total expenditure and cost to our healthcare system.
Why ovarian cancer? If the technology is suitable for detecting cancers in general, was there something special about ovarian cancer that made you pick that, or some other reason? Economic reason or clinical reason, technical reason?
Well, the reason that ovarian cancer is so interesting is because it's so difficult. And there's not a lot of people willing to take that challenge and try to conquer such a difficult disease. The ovaries are difficult to get to. They're not well understood in terms of how the cancer metastasizes. And it's really important to put work towards things that aren't easy.
A couple of questions. You had 2K to 10K in terms of the cost. That's a pretty big spread. Why such a big spread?
It depends on the institution.
It's not about the equipment.
No.
Okay, you have a pretty good peg on what the equipment would cost?
Again, these were things that were conceived over the last few dozen hours. So that's part of the reasons that there's such a spread is we haven't quite nailed that down yet. We looked at other similar types of procedures, and that's where we came up with some of those numbers and why there is a larger range on it.
Okay, so you've been working on this for a little while. Have you filed provisionals?
No. The multiphoton, I'm using a multiphoton microscope, and the technology is already patented. It's not a new technology. But the portion that is yet to be developed, which is the endoscopic portion, has potential patentability.
And is this, are you using just high resolution, or are you using light reflectivity on different? Is it just that you're getting a real clear look at this and you can get high resolution, so you look at morphological changes?
Yeah, so the high resolution is the nature of the system, and it allows us to see the high resolution changes.
So I have a question right along those lines. So first piece is, it sounds like you have multi-photon approach to imaging, and you get very high resolution that way. The other question I have, so that's hardware, right? Are there algorithms that you're applying?
Yeah, so what I'm seeing with the multiphoton microscope is the collagen structure in the tissue. And the collagen is what gives structure to a tissue. And as cancer starts developing, the cells start growing and start disturbing that native collagen structure. So it's the changes in the collagen structure that I'm seeing and that I'm able to classify with the algorithm.
Okay, and so have you considered patenting the classification algorithm and then tying that out to the hardware so that you have, in other words, someone has a patent on the multiphoton microscope, and there might be patents on the endoscope, but you might be able to wrap that around, right? Put another patent around it that has your algorithm, thereby putting you in a position to do a great deal with these people.
That is
Have you
possible.
thought about that?
Thank you.
All right.
One last question.
Real basic question. How big is the addressable market?
So there's 2.5 million women at risk. Those are women that need to be screened. 2.5 million women in the U.S. over the age of 45. I haven't done enough research to be able to tell you that.
It's good. Thank you very much.